Hi there, my name is Kaylee Kruzan, and I'm a research assistant professor at the Center for Behavioral Intervention Technologies in Northwestern University's Feinberg School of Medicine. I'll be presenting today on some work I did with my colleagues where we investigated the potential of a self-tracking technology to assist primary care patients in managing their mental health symptoms. First, it's important to note that mental health conditions are incredibly prevalent worldwide. And in the US, symptoms of depression and anxiety are often first discovered in the primary care context when people go in for routine visits. While it's great that more people are being screened and their symptoms are thus known, many people who are diagnosed in primary care settings do not receive treatment. Because primary care is not set up to provide mental health treatment, many people are often lost in the transition from primary care to offsite referrals. In our work, we argue, like others, that digital mental health interventions can help bridge this gap from primary care to the receipt of mental health treatment. So what are digital mental health interventions? Well, digital mental health interventions are typically described as psychological or psychotherapeutic interventions delivered in part by technology. And there's been an increased interest in these devices because they have many good qualities. For example, these interventions are scalable and can reach many people. They're cost-effective, they're efficacious, as shown by several meta-analyses, especially for depression and anxiety. They're acceptable to many different populations and groups, and they're flexible in terms of format and platforms and functionalities. Digital mental health interventions increasingly incorporate self-tracking functionalities, which can support cognitive behavior therapies focus on increasing an individual's awareness of thoughts, attitudes, emotions that impact mental health and well-being. And CBT is the gold standard treatment for anxiety and depression. This tracking can occur manually, or it can occur passively, which relies on sensors in the technology itself that can collect continuous data on several behavioral and physiological markers that are related to mental state. However, research in this space has shown self-tracking can lead to a heightened sense of awareness of symptoms that becomes overwhelming or discouraging for some users and can ultimately lead to discontinued use. Additionally, there's more research needed to understand what users want and what indicators are important to them. And data don't always provide clear paths for action. There's usually a need for additional human support or interpretive support. So in this study, we had several aims. We aimed to better understand the value of digital mental health interventions that incorporate sensor data for primary care patients with symptoms of depression or anxiety, specifically by exploring individuals' mental health self-management practices, their interests and preferences for a self-tracking technology to assist them in mental health self-management, and their envisioned comfort with sharing data from digital mental health interventions with primary care providers. The approach we used here was a semi-structured remote interview because this occurred during the COVID pandemic. We interviewed 10 participants from a large urban healthcare system. You see here the inclusion and exclusion criteria. Sample was mostly female, diverse in terms of age, race, and ethnicity, and represented the population accessing care within the system. Data were analyzed with conventional qualitative content analysis, and this analysis is described in detail in the paper. So here's a summary of our findings. There were 5 broad buckets that I'll go through briefly. So experiences with mental health symptoms. We found that patient understandings of their mental health were also characterized by periods of good and poor mental health. In periods of poor mental health, participants noted decreased enjoyment and motivation in daily life, a sense of uneasiness, and increased difficulties interacting with others. In terms of mental health self-management practices, patients noted that these were similarly bifurcated into active symptom management, which corresponded to poor mental health, and mental health maintenance, which correlated with good mental health. In periods of good mental health, participants were more regularly engaged in activities that lifted their mood, like exercise, connecting with others socially, and the ease with which participants engaged in these activities was a sign of good health. Poor mental health was characterized by symptoms that made it difficult for participants to engage in these activities, and often required participants to take action in other ways to rebuild momentum. They described engaging in focused activities that brought them a sense of accomplishment, productivity, and enjoyment. These activities were small and task-based, typically. So most participants reported some form of tracking physical health with wearables, but there was limited tracking for mental health. And so participants that did use self-tracking for mental health largely discontinued use because the tools were not perceived to be useful, suggesting a need to reevaluate the utility of these technologies in the mental health space. When asked if and how they might envision a self-tracking technology being useful for mental health, participants described two functions. They wanted to quantify the daily self-care activities that they engaged in. Rather than emphasizing symptoms, participants really wanted to see what they did to help themselves on the daily basis. And they wanted to begin to discern patterns, so identify triggers and contributors to mental health symptoms, and be able to do something about that with that knowledge. We also found that participants saw value in sharing data with providers for two main reasons. They envisioned that sharing mood or passive sensor data with their provider would help the provider to alert them to declining mental health. They also imagined that sharing data could help them to initiate conversations with their primary care provider about their mental health. So collectively, our participants spoke about technology needs, and in considering these needs, we felt it was necessary to comment on or consider potential service needs to ensure that the technology could benefit participants in moments of poor mental health, while also fitting within a primary care setting. So first, sensor data are often used to send users insights during periods of poor mental health and in an effort to empower them to make changes. However, behavioral markers from sensor data were perceived to be most valued by participants when they were maintaining mental health, so that is when they had good mental health. Sensor data could be used to accommodate for shifting needs and provide differential feedback during these periods. Given that our participants described symptoms that affected both motivation and ability to engage in activities, and the longstanding concerns around digital mental health engagement, we recognized a need to explore novel ways of supporting user engagement with treatment. One way this is done in clinical science literature is through the design of complementary services or wraparound services, including low-intensity coaching, which we describe in more detail in the paper. And that's it. Thank you so much for listening.